Hello, everyone. You're here for digital and data literacies in health, what adult learners know, learn, and do. We do see people filtering in. We'll allow some time for that number to stabilize, and then we will hop into it. And I invite you to, if you know somebody on the screen, you can say, hi, nice to see you. If you don't know anybody on the screen, you can introduce yourself. And then the next time we see you on the screen, we'll be able to say, nice to see you again. Do you see that Lori Hano is on the participant lineup? And it gives me an opportunity to thank Lori for a lot of the behind the scenes work on this conference and for helping this session pull itself together in relatively last minute kind of ways. But teachers know how that works. And so here we are. Okay. Okay, I'm seeing the numbers kind of slowing down around 55. And so I think, see, I'll wait till it hits 60. It's like watching the gas meter when you don't want to spend over $25 in gas. Okay, wonderful. And Greg O'Neill, are you and I the only ones here from Delaware? I am now based in California, but I grew up in Seaford, Delaware. So it's always cool to meet other folks from a very small state in the country. Okay, wonderful. Well, welcome everyone. We're going to go ahead and dive in. As you know, this is being recorded. And so just a few housekeeping things. You are here for digital and data literacies in health, what adult learners know, learn, and do. A common focus among the panelists that are here today is that we all have a very vested interest in the adult educational system, the adult education system. One of our colleagues is squarely in public health. The rest of us are here as good guests in this discipline. Many of us identify as adult educators, applied linguists, working in community-based settings. And we definitely hope that bringing this perspective from the adult literacy sector, from the adult education sector, adds to the conversations that have already been taking place here at HARC. And again, a thank you to Lori and Michael Pasha-Orlau for allowing us to give a shout out to the adult ed system, which we hope that this session today will help highlight. I'm here just to present a very short overview of what you're going to hear this in this session. We're trying to present multiple perspectives on digital literacies and data literacies with a very strong attention to the learning of these areas, the exploration of new practices in these areas. I am speaking to you from Northern California at San Francisco State, where we have a very strong social justice mission. We also hope that the connection between an investment in education around digital literacies, around data literacies, is viewed as part of what is needed in order to have equitable outcomes. I'm going to offer a few introductory remarks, mostly to give you some questions to think about as we go around the room and the virtual room here and listen to different perspectives, and some questions to think about. Afterwards, I will pass it to Jill Kastek of University of Arizona, who will be giving us some core definitions, and that's why she's going first today, around digital problem solving and adult learning issues in healthcare context. And so if you're new to this field or this arena of thinking, we're hoping this will provide at least a good introductory primer. Kathy Harris and Julie Reeder, coming to us from Portland, will be talking about conceptualizing e-health readiness, highlights of participant experiences with the Oregon WIC program. And so we're starting to dive into context, and how that matters. And that theme has already been heard in many venues this morning at HARC. We then move over to Minnesota and we'll listen to Teresa Sladek talk about digital health literacy and an assessment system that exists to be able to understand what are the needs of participant groups, communities around digital literacies, assessments and training tools to help adult learners gain digital skills necessary in accessing healthcare. We'll circle back to California to listen to my colleague, Maria Jose Bastias, who's going to look at another part of the picture around digital and data literacy and data justice. Latina Indigenous women as data storytellers, new opportunities for linking health literacy, data literacy, and social justice. Please know that after each presentation, we will allow a minute or so for a quick clarifying question or an airing of a burning comment. So feel free to use the chat and the Q&A. I will monitor that and give one opportunity for some interaction so that we can break up this longer session. And then at the end, we're going to return to a more dedicated Q&A. So just a few minutes here of what we're doing together and this group of great thinkers that the session has been able to bring together. A myriad of universities, university-based initiatives. Please screenshot this slide. Make sure that you can explore the websites and the different offerings. Everybody on the screen is thinking about the link between learning, engagement, data literacy, digital literacy, and the equitable outcomes that we're all striving for, and really trying to center this discussion around how are we thinking about that learning and engagement process piece. And with that in mind, I'm going to throw out 3 questions that I'd like you to think about as you listen to our panelists today. And the first one is, whose experiences are driving the narrative about low digital, low data literacy in healthcare? And low is deliberately placed in quotes because we're hoping to take some critical reflective stance on that very question. What myths about digital literacies, data literacies need busting in healthcare? You will hear some of the presenters identify explicitly some myths that have come up in their own work and the ways that their own work in the field and research is helping to bust that, and to invite you to think about what additional myths that need to be continually busted. And then finally, as I reminded you, many of us are teachers here. We spent a lot of time in the classroom thinking about the learning that goes into digital literacies and data literacies. And so as that ecosystem is continually evolving, new apps, new platforms, new opportunities, new interactions, new healthcare arenas, how do we know what skills to teach and learn? We're obsessed with this question, and we hope we can invite more conversation into these areas. So if you need to leave or you get hungry, you got to step out, I'm just going to present you with 3 ideas that I hope are kind of at the core of what we're trying to get at today and are about really knit us together in the conversations we've been having to prepare for today. So why are we here? We really want to push the debate about how we're conceptualizing digital literacy and data literacy by elevating this focus on learning and engagement. Here's our basic premise, is that we really do need more nuanced frameworks informed by pedagogy, informed by meaningful engagement, informed by participatory frameworks. And we need more learning opportunities that really lean into the personal, collective, and performative. And by that, I mean, and that's reflected in our title, the hands-on doing, experimentation, exploration. You don't go to a class and come out knowing how to use email. You get some ideas, and then you go out in the world and you email a lot. And that's how we got better at email. And so this performative piece is something that we're trying to take a closer look at today. And we hope it raises new questions. We've got some worries as well, given the current climate of investment and development of tools. How useful is any tool, any conceptualization of these literacies, if we privilege the development of tools and platforms to the neglect of meaningful learning and engagement opportunities? And that is a question about disproportionate levels of investment in the tools versus the engagement. And we hope we also raise questions about that today for you. So with that, I'm going to pull down my slides. I'm going to turn it over to my colleague, Jill, who will take us into a deeper dive into conceptualization of key terms and anchoring ideas. Thanks, Jill.
It's a pleasure to be here with you today, and I really appreciate the opportunity to spark conversation in this particular panel. Can everyone see my screen okay, or should I go ahead and full screen it here? Better? Okay.
That looks great, Jill.
All right, thank you. My name is Jill Kastick, and I'm coming to you from the University of Arizona, but this work is best done in collaboration with many colleagues that come from many places and many disciplines. And so I just want to give a shout out to all the collaborators that supported the ideas here in this particular presentation today. I wanted to start by talking a little bit about the digital world, because we live in a digital world that's constantly changing and constantly evolving. The digital world requires that individuals use digital tools every day in problem solving, and this connects directly to health and wellness. The ability to problem solve life's challenges with the help of the internet is a learned set of skills and strategies and abilities, and it takes a lot of practice. Without these abilities, individuals are less able to take part in online services offered by health and social service organizations. The digital world is multiply nuanced as well. We've got the health context. We are being asked constantly to fill in online forms and applications, access education, finance, and a number of other things. It's constantly changing, and it requires a set of skills that need practice in multiple ways. And so I'm going to start by offering a myth, which is having a digital device, a phone, a tablet, a computer, and gaining digital skills is sufficient for navigating one's e-health. What is required isn't just access, but instead the ability to think about and engage in a process of digital problem solving and resilience. And so in thinking about this presentation, I wanted to be more concrete and specific about what the difference is between digital skills and access and digital problem solving and resilience. Digital skills is about using devices for particular uses, such as finding information on the internet, understanding how to be safe and responsible online, communicating socially and professionally. And this definition comes from the Digital Us Coalition. You might notice that this is about the use of devices. This is about the use of particular platforms for doing particular things. However, because the digital world is constantly changing, I want us to move closer into the column on the right and help us to think about digital problem solving. Digital problem solving is the nimble use of skills, strategies, and mindsets needed to navigate online novel resources, tools, and interfaces in an efficient and flexible way to accomplish one's goals. And this really does involve the constantly changing, rapidly evolving set of things we are required to do online. Not only does that require digital problem solving, it requires digital resilience, the awareness, the confidence to navigate and rapidly change according to digital transformation and have confidence in this process. And so if digital skills are not enough, how do we think about the evolution of digital problem solving and digital resilience? Well, we look around us and be able to see where people every day are looking for reliable health information. There, although we may think that all health information comes from reliable sources, many of the reasons people use the internet is to be able to Google symptoms, to be able to use symptom checkers, to see what's on the news, and to even get their healthcare information from social media. So in order to really capture an understanding of how people are using the internet for health, a group of us, many of whom are in this room, have developed a scenario-based digital problem-solving assessment situated in the use of information within healthcare contexts. Why scenario-based? We really believe that these digital problem-solving skills require a situation in which health is the necessary context. So due to the rapidly evolving digital landscape, we know that these constructs are constantly changing, but we developed this scenario-based problem-solving assessment to really anchor into 3 important areas of digital literacy, meaning critical evaluation of online information, internet safety and security, and device literacy. And these 3 we felt were really important to tap into when it came to what digital problem solving skills do our population do they have. So an example of critical evaluation of online information, you may want to test yourself and place your own answers into the chat if you're so inclined. But here's a sample situation. If you could give your sister one piece of advice about safe ways to get information she can trust online, it would be taking time to verify online, info with other sources, posting about solutions on social media, looking for an organization that knows about health and causes and following their website, Googling the problem, looking for a Facebook group. You may in your mind already have an idea of what could be a green light, what could be a red flag, what could be a caution. And this kind of question may seem particularly obvious to you, but in a minute, I'll show you some of the patterns of results from our population. Here's one about internet safety and security. This pop-up message asks you to accept privacy terms. What happens if you click accept? This site gets bookmarked. You have a purchase history. The site collects information from your computer, such as search history. You follow blogs, or you get the healthline.com newsletter. So you have to really understand, what are privacy terms? What are they asking you to accept when you accept such things? And this may seem obvious to you, but again, I'll show you the pattern of results in just a minute from those in our population. Here's an example of device literacy. Your doctor's office is offering video appointments to meet with your doctor online. What would you most likely to have if you want to make such an appointment? Do you need a voice and camera on your device? Do you need Facebook Messenger? Do you need the ability to upload pictures? Do you need a health tracking app? Do you need to bring all of your health records to this appointment? Again, may seem obvious to some of you in the room what these kinds of needs are, but it is tricky to think through all of the complexities of what it takes in device literacy to have an appointment with your doctor online. So here's the pattern of results I wanted to introduce. We had a total of 17 of these problem-based items that we presented to a group of individuals. There were 27 participants in our population. We had a cut score of 12 correct answers, and 93 of the individuals fell below the competency cut score of 12 items out of 19. This is very problematic when we think about how much people use online information for their health. So breaking this down a bit further, we took a look across all 3 of the kinds of information resources: critical literacy, internet safety and security, and device literacy. And we chunked that out by those who had a high school accomplishment or less than a high school diploma. And there were no real differences between participants with a high school diploma or above or less than a high school diploma. This signals that this is not as much related to people's educational accomplishments as it is to experience nested experience worked with health situations and navigation of information. So I will contend today that individuals need problem solving and resilience, and to work on this within and beyond healthcare. These learning aims are an important extension of just digital skills like communication or learning to use your tablet or internet searches, and are not gained just with having digital access alone. It requires a lot more in terms of education. What's needed?
Jill, just really quickly, 2 minutes.
We need more digital problem solving and digital resilience. It requires contextualized practice and health context for all learners, not just those that we think may need this, but all learners. Support for learners need to go beyond providing just device access. And we need more partnerships between education, adult education in particular, health, and I think one accomplishment is finding wide-scale community partnerships like the ones we will be talking about today. Thank you so much.
Thank you so much, Jill. There was a great comment in the when you were bringing up the slide of where do people go? And Sean says, was really hoping Medline Plus would made that list of digital resources. And I'm wondering if you have a quick comment on why isn't a Medline Plus, or what are the social dynamics or the issues that might complicate that, maybe from the resilience perspective.
I really think it's ease and people trying to get information quickly without a whole lot of digging into terms and terminologies and where's the information coming from. I think people do a lot of this on mobile devices on the go, and reading a Medline Plus informational website maybe is not as accessible for somebody who's going from a bus stop to a doctor's appointment on their telephone. So I'm gonna hope that we get more conversation around that in our next after all of us go in this panel. Thank you.
Wonderful. Thank you so much. And with that, I will punt over to Kathy and Julie.
Great. Let me just get my slides going here. Whoops. Give me 1 second. There we go.
Okay. Hello, I'm Julie Reeder with the Oregon Health Authority, and I'm presenting today with Kathy Harris from Portland State University, the Literacy, Language, and Technology Research Group. We have worked together for many years, and so if you're coming from public health or healthcare like I am, I really encourage you to get to know people who work in adult basic ed or adult foundational education, because sometimes in healthcare and in public health, we're not honest with ourselves that sometimes we're not the experts on this. And so when I'm thinking through literacy problems and connecting well with audiences with lower education, I always think to myself, I think that adult basic ed, adult foundational education folks are really the people that we should spend some more time with. So that's my little plug from the public health and healthcare side point. And today we're going to talk to you very quickly about the highlights of our study and our experiences with Oregon WIC participants. So really quickly, because we have some international folks sometimes, WIC is a public health nutrition program for pregnant and postpartum individuals and children under the age of 5. You need to be generally Medicaid eligible, so it's lower income families, but families with young children, so under the age of 5. And so back when COVID came around, WIC visits typically are in person, but we needed to switch to having remote visits, which was brand new to us. And of course, everyone came and said, well, state WIC program, what kind of amazing platform are you going to provide for us to do this? And knowing in the past that, we've had problems even with the technology just to set up, your PIN number, right? For use of electronic benefits, or from the staff side that we've had issues with just even trying to do an iPad check-in where people sent those back to me. We thought we had better do some taking a look, about readiness to take this on, and really looking at digital literacies among staff participants and actually our IT staff out, because public health is a lot different than a large healthcare system. So what did we do? Back in 2021, we distributed a survey via text to WIC participants, and we were looking about feasibility and equitability of moving forward to offer some video-based visits. We heard from 9,503 WIC respondents. And there was an option to do the survey as well over the phone, because obviously it's hard to say how's your digital literacies, only for those who have enough digital literacy to do an online survey. And we also did separate surveys of WIC staff and IT staff. And we did a follow-up piece assessment with 30 individuals, English, Spanish, and Russian, for additional details. And we looked at things like comfort levels with video, use of the internet, what are people already doing with the internet or not, reading the news and social media and so forth. So really a broad spectrum of things that we looked at. Next up. Thank you. And so just to give you some information, and again, kind of why this overlaps with adult basic ed or adult foundational education. So while the vast majority of participants in Oregon WIC have at least a high school diploma, and we definitely have people with some college, right, an associate's or even a bachelor's degree, we do have a significant portion of people as well who have less than a high school diploma or even less than 9th grade. That's primarily our Spanish-speaking population, but so we have the full spectrum of folks, but we also, have some overlap with adult basic education. And we did the survey was in English and Spanish and Russian. That was just what we had the capacity to do. Of course, we have other language, but that reflects the majority of the Oregon WIC population. So we did cover the 3 languages. And so now over to Kathy.
Great. So I want to kind of talk about our study results a little bit. And first of all, I want to present a myth. And that's the myth that everyone has a smartphone, so everyone has access to the internet. We've actually heard people say this everywhere, from our Congress people to local people. I mean, it's sort of everywhere this myth is. But what we discovered is when we asked our participants who doesn't have a smartphone and then sliced our data in a variety of ways, it turns out not everyone has a smartphone. Among our Spanish-speaking respondents, 28% report that they don't have a smartphone. Sliced another way, 13% of our participants said that they, if they had less than a high school diploma, they did not have a smartphone. And sliced yet another way, 14% of non-white participants did not have a smartphone. So we can't, obviously there's overlaps between the way we slice the data, but we can't assume that everyone has a smartphone, because not everyone does. We just can't make that assumption. So that's one of the myths I want to bust. Now, participants connected to that is many people use their smartphones to access the data. To access the internet. But if we have to ask ourselves, okay, if you're using your cell phone to access the internet, how often do you run out of data? Well, only about half of the people never run out of data. 18% run out every month. 14% run out every few months, and 12% run out a few times a year. So what that tells us is even if people have a smartphone that they use to access the internet, that doesn't mean they can all the time. So that's another piece of the puzzle we have to really understand, is that even with a smartphone, not everybody can access the internet and access services that they would need the internet for. The other thing is, when people don't have data, what do? Well, about almost half of the people in our respondents have to go somewhere sometimes to get the internet, use free Wi-Fi. So about 50% do sometimes. If you're Black, almost 60% of people say sometimes, and Indian and Alaska Native also about 60% of the time. About 60% said that they sometimes have to go to public spaces to access the internet. Public spaces are places like Walmart parking lot, Home Depot parking lot. These are places where they've offered their free Wi-Fi in their parking lot at all hours of the day and the night. which is where people go when they can't access the internet through their phone or through some other source if they don't have private internet and broadband internet. So we also asked people, what help would you need? These are WIC participants. What help would you need if you were going to do a video visit with WIC? We asked them, would you need help getting access to reliable internet, access to a device, tech support to do the download of the app or the platform, tech support for logging in, finding a quiet place to have a visit, or navigating the technology in English? So we asked all of our participants those questions. And what they said is, people would need help getting out doing a video visit. So they would 23 to 24% of our participants who prefer their services in Spanish said they would they would need help getting access to reliable internet. 40% of the participants who prefer Russian services say they would need help navigating the technology in English. Whereas help finding a quiet place or a private enough visit, 50% of the participants who would prefer English services said they would need help finding some place that was quiet or private enough to have a virtual visit. And 24% of our participants who would prefer services in Spanish said they would need help finding that quiet place. So there are definitely things that we have to ask ourselves about what access people have. And that's not even, never mind. I'm going to keep going. Myth number 2, people are comfortable with privacy in their telehealth visits. Now, this one, I think, really did come about as a question. I think people assume that there's privacy in their video visit, their telehealth visit. But what we discovered in our interviews, especially, we gave some nuance to this. So we interviewed 30 people following up from this larger sample, and we were able to get some nuance. In particular, we asked about discussing sensitive or private topics. So for example, breastfeeding support is one of the things that you do in a WIC visit. So you're trying to figure out how to get the baby to latch on. Are they eating, are they eating properly? So you're, really showing your breasts and you're showing the baby, and it might be really close up. So it can be quite personal. And what we said, we kind of had things coming in 2 sets. On one hand, and the quote on your left shows us, people worried about who was on the provider end of that video visit. They didn't know who else was in the room. They could only see that provider that they were having a conversation with. And so they really worried about that. One participant said, it would be very different from in person because video call, at times you might think that someone else is watching or listening because you don't know who else can be there besides the doctor, right? But on the other hand, is that the participants said, I don't have a private place at my house or at where I live. So the kids are like pounding on the door. I want to come in, and everything is like a mixed bag. Yeah, not much privacy. So people talk about wanting to have personal conversations with their provider, but not having a place that either was visually private, but also private from hearing. And they didn't really want to talk about some of these confidential things in front of their kids or their partners or the other people who live with them. So those are the two.
Just a couple minutes left. Thank you.
Okay, thank you. I'm going to keep going then. So one of the things that really appeared in our data, and especially the interview data, is that the barriers stack for people. It seems like you might think starting on the left, you might think it's not really problematic to have to use cell data to use the internet. But that's just one problem. That's one piece. That's one barrier. So if you move over to your right a little bit, people with that problem may run out of data and have to go somewhere else to have a virtual visit. And then that can add a barrier. And if you move over a little bit, at that place, they may not have privacy for their visit. They may be in the Walmart parking lot in their car in order to get the Wi-Fi that they need in order to have that video visit. That can add another barrier. They also may worry about who's watching at the provider office, then move over to the right a little bit. Each of these stacks up to be a barrier. But then if you are trying to have this video visit in a language that you're not confident in, that's another barrier. Or if you're trying to do it that involves, if you don't have strong reading and writing skills, that's going to add another barrier. And each of these barriers stack on top of each other. So at the end, while any one of these things may seem like a surmountable barrier, when you stack them together, they're a big, strong barrier that many of the patients that people have are experiencing. But oftentimes the people working with them only see one of those barriers, but in fact, they stack and they get to be bigger barriers. All right, Julie.
Briefly, so we sort of have a call to action at the end of our presentation. And it's really, if you're coming from a public health program or healthcare program, is to really clearly understand the digital literacies of your population before adopting technology solutions. Often we don't do that. We adopt the technology solutions and then we think we'll catch up those who might have issues down the road. And we know that just really piles on to the existing disparities. So I just really implore you to clearly understand the digital literacies and try to measure as subjectively as possible, because self-report is limited. If you're a funder, when I go on the healthcare side, when I'm in sort of venture capital things about wearables and all those types of things for the healthcare tech sector, I never really hear anything about digital literacies. And I don't hear equal funding for building digital literacies anywhere close to all the money that goes into devices and monitoring. Finally, engaging with tech developers to increase understanding of health and digital literacies. I rarely hear that when we're talking about the development side of everything, from Epic to, again, these wearables and other types of tech devices. And finally, we're probably all familiar with the 508C and the Web Consortium accessibility guidance. And so when I am approached by vendors for tech, for WIC, they always talk about those things, but we don't have something similar for what should take into account digital literacies. So I just encourage us to think, from top down, from the funding that we receive to talking to our tech developers and then thinking about what our standards are. We could do so much more to really be digitally inclusive for lower income populations like WIC. Thank you. Appreciate it.
Thank you so much, Julie and Kathy. There was a mention of something I learned out recently. Kathy, and you and I met with the folks in Delaware who were looking at the telehealth boxes in the public libraries. I had the opportunity to visit one and learned that in Southern Delaware, it actually didn't last very long. People weren't utilizing it as much, and they really, I have not seen any kind of evaluation. But might there be something in your work that would promote the idea of these community-based spaces that might dovetail with, like, that's where you go for childcare or you go for an after-school activity, and then would double as an opportunity to sit in a box and be able to access these services? Did anything that might respond to the comments in the chat?
It's really hard to say, but people don't think of having video visits with their providers in those spaces. It takes a mind shift, I think, on both the provider side and on the patient side, to be thinking about other places to go for that kind of service. I mean, I think that there's a big mind shift that it would take.
Thank you. And that's raising lots of interesting commentary in the chat about telehealth. Alex, we'll come back to your question at the end. Thank you so much, Julie and Kathy, again. And I am going to shift it over to Teresa.
Well, hello, everyone. Thanks for being here and for joining us in this conversation. I am Teresa Slottick, and I am with Literacy Minnesota. And we are, I'll tell you a little bit about Literacy Minnesota so you can see what background I'm coming from. So Literacy Minnesota, we are a nonprofit. We've been around for 50 years, and our primary focus that entire time has been working with adults on literacy, especially English language learning, reading, writing, and numeracy, citizenship, and now digital literacy. We have actual schools in the Twin Cities of St. Paul and Minneapolis. And then we do statewide training too for teachers and volunteers who are working in this field. So we're firmly in the adult education sphere. We also have developed a platform called North Star Digital Literacy that is being used by over 3,000 subscribing organizations. And when I say subscribing organizations, those are places like libraries, workforce centers. Now more and more I see healthcare centers, community-based organizations, adult education. And And there's also, North Star is also available free to individuals. So what is North Star? It's a platform to assess and then educate people around basic digital literacy. So in order to get to that digital problem solving, you still need the digital literacy first step. And so we're talking about how to turn on a computer, how to use a mouse, how to use email, how to even search on the internet, these kind of basic foundational skills. And we, in a nutshell, I can talk about North Star for hours, but in a nutshell, we have 15 different assessments, again, starting from that really basic computer use, kind of going up through, I'd say, mid-level knowledge of different digital programming or uses. And then we have the assessments that people use to say, okay, this is what I know already, and this is where I have an opportunity to learn more. And then we have two types of educational materials tied to that. One are kind of self-directed practice lessons that people can do more or less on their own. And then the second type would be an instructor-led curriculum that you'd see more in a training or a class or used by a digital navigator. And tying all this together, and how we always start with our different unit topics, are standards. So the standards help inform, these are the skills we feel are necessary to be competent in this area. So for example, we have, that's more pertinent to this conversation, one of the topics that we look at is how to access telehealth appointments. And when we created those standards, Marisol helped in creating those. We had several experts across the country who are experts in telehealth help us develop those standards. And because we work with adults on literacy, we wanted to make North Star as accessible to the population we work with as we could. So we wrote everything at a grade 4 reading level. Now, there are people who use this who have a lower reading level, either in Spanish or English, are the two languages we currently are in. And that you can use North Star with that population. It just requires more effort on the part of the instructor. So there'd have to be probably more repetition, you'd go slower, and you'd have to build in maybe some other literacy around the digital literacy. And it's also web-based, so if you have a device and a stable internet connection, you can access it anywhere in the world. So as we're looking at the unit on the accessing telehealth appointments, this is one of the newest topic areas because we were hearing from across all of our subscribing organizations, this was a need from the learner perspective, and then also in talking to a variety of different types of healthcare organizations, it was also seen as a need from that viewpoint. So the assessments themselves, anyone can take them, they're free, you can find them on our website. And in the last year alone, 15,000 assessments just on the telehealth appointments have been taken. So you can see that people are interested. I don't know how well you can see this screen, but when I was talking about the standards, these are the telehealth standards that we base the assessment and the educational materials on. So you can see the standards are very, very concrete and testable. So, can you log in and sign out of an online health portal is one of the standards. And in creating the assessments, almost all of them, except for the basic computer skills, are scenario-based. So a real-world scenario that an adult may find themselves in. And instead of asking theoretical questions, do you know this? You have to actually show that you have the skill. So in this case, the person would have to click the unmute button to show that they had that skill and they understood this question. Once you finish the assessment, each person will get a results page. And, North Star says you have to have 85% or higher to pass. But what's more important is on the left-hand side, you can see in the green column, these are the standards that this person has passed. It's a no. And in the gray column, here is where they have the opportunity to learn new information. So it can be really helpful for people to understand where more instruction is possible. And as the other panelists have talked about, we often think about people not having digital skills who are maybe older, or that it's not really a big problem. But as you can see in the middle column there, 32 million people, adults, don't know how to use a computer or don't have basic digital literacy. That's a lot of people. And it translates into about a third of the US workforce in general, but it's disproportionate to people who have historically been underserved. So although a third of US workers in general, but half of Black and Latino workers have limited or no digital skills. So this is looking at workers, but you can translate that into people who may be using telehealth as well, or healthcare. And I think too, we talked about digital resiliency. A lot of people too are not comfortable using with their digital problem solving skills, as we talked about that before. Not just older people though. It's also can be, I hear about all generations not having computer skills. So some of the barriers that I have seen in my work, my role is I work with our larger partnerships, and I do a lot of training and hear a lot from the organizations that use North Star, is that many people who have low or no digital literacy skills are very afraid of the computer. They're actually afraid they're going to break it. They're afraid they're going to get in there and mess everything up. And what's even more telling or important is that they're really afraid of their own ability to learn the skills. So there's often just the barrier of helping someone to see that they have the ability to learn this new material. And what can often push people even farther on the anxiety scale, I guess, is that healthcare providers, their job really is to provide the healthcare. And they are really busy. And it may be that they don't have the time or the kind of knowledge of how to work with people who are worried, who are anxious about this, who don't have the skills. And so they might use jargon, or they might just assume that people know things, or they might kind of rush it. And that's going to just increase that anxiety and make people less willing to learn these new skills. And there's also, we talked about some of the mistrust that Kathy was talking about, but there's also historical mistrust toward the, government, healthcare agencies, that especially some populations have been abused. And so there is this mistrust of, if I do something digitally, where's that information going? And then on the healthcare provider side, sometimes there's a question of, is it really worth the time for me to educate this one person, when I have a million other things to do? And so then it's not done. So as we look at kind of solutions or helpful perspectives, maybe.
Hi, Teresa, just a couple of minutes left. Thank you.
Thanks. So one of the things we want to look at is the language of digital literacy is almost as important as the skill. It's another topic that people need the language, so that they're not turned off by that jargon they don't understand, or those words they don't understand. So making sure that digital literacy and the terms are also taught in conjunction with the skills. And you also want to make sure you're meeting people where they're at, though, that your explanations are simple, that you're not assuming prior knowledge, that you're starting from the beginning. And it's hard to remember what that's like if it's probably been a while since you didn't know how to use a computer or use a mouse. And taking the patience, having the patience, taking the time, and again, teaching that additional vocabulary that may be needed. Making it a safe place to learn these skills. And oftentimes it helps to have trusted community members that are teaching. So we released North Star in Spanish, and one of the groups that first used it in Spanish was a library in Texas that they were having classes. Their first cohort, was all being taught in Spanish. And it was hard. It was hard for them to get people to agree to come to this cohort. And, as Kathy said, there's a multitude of barriers. And one of the interesting things was they got this group of people who committed to coming, I can't remember how many weeks, and their preferred language was Spanish. And they kind of, the learners themselves kind of dictated how they wanted to use North Star in Spanish. So what they preferred, which I thought was really cool, was they wanted to take the assessment in Spanish, obviously, to show their digital skills without the barrier of the language skills. Then they wanted to go and learn the material in English because they wanted that terminology. But when they came to a point where they didn't understand kind of how to do something in English, then they would go into Spanish, learn how to do it, and then go back to the English to learn the terms. They would then, follow up with the assessment again and pass in Spanish, and then they wanted to pass it in English. So this is what the learners themselves wanted. And when the second cohort time came, they went out into their community and they talked about how great this experience had been, how heard they had felt, and they had a waiting list for the second cohort. So it was just, they got the trusted people in the community, went out and talked to the community about this, which leads to that last point of, is it worth spending the time to teach one person? Well, one would argue always yes, but it can be much bigger impact than just one person, because that person is going to go out and teach other people, and they might teach their parents, they might teach their kids, they might teach their friends. So it's really multiplies the impact. And I know Maria is going to talk more about the community impact. So I am going to turn it off.
Thank you so much, Teresa. During your talk, there was a question from Samuel about the AI directions. We knew there was going to be a question about AI. We won't answer that now, but I invite everyone to think about that as we head towards the Q&A. But our last panelist is Maria Jose Bastias, who's going to shift attention to data literacies and data justice. Thanks, Maria, and thanks, Teresa.
Thank you. I want to start saying that my internet has not been friendly this week. So if something happened, just let me know so I can quickly change. Thank you. All right. So I'm going to start sharing my screen right now. And can you all see my screen?
Yep.
Perfect. All right. So my name is Maria Jose Bastias. I'm an EDD candidate at San Francisco State University, and today I'll be sharing my work and research here in California, advancing communicative justice in the classroom. Oops. This is the fabulous team I get to hang out with. And I wanted to start showing you this because I think it highlights the relevance and the implications of connecting health data and digital skills and bringing all of that into adult education for multilingual speakers. Communicative justice. Oh, sorry, I meant this a little bit. Communicative justice seeks to change the way we think about health data by changing the way we engage adult learners as data creators, data storytellers, and data visualizers. And I also have a myth. When we think about data scientists or data savvy individuals, we may not think about adult language learners or patients. So as an adult foundational skills learners, you can advance data justice. That's the myth. But on the right side of your screen, you'll see a poster that my students created advocating for the bill SB 686, Health and Safety for All Workers here in California. Unfortunately, this bill did not pass, but it was key, it was essential for them, the whole process, because it showed them, they learned that the lack of representation of them not being counted really affects policies, regulations, and even the access that they can have to health services. So in this presentation, I'm going to share briefly, because we don't have much time, the work that we have been doing in combining data, health, adult education, and social justice. So communicative justice has 5 domains: understanding data, learning to speak data, playing with data, data storytelling with a purpose, and curiosity and courage. Once again, I have to go through these very quickly. I'll be happy to talk more afterwards. If we look at the domains closely, we can say that to understand data means asking essential questions like what's data, who works with data, does data actually improve our lives? Learning to speak data implies using language, learning and using the language to talk about data. Frequently, learners, patients don't feel confident to talk about or have conversations about data because they don't feel that they have the knowledge about data itself, or they don't have the language to talk about data. And like Teresa was saying, it's important to acknowledge that these conversations and that this knowledge doesn't have to happen in English. It can happen in other languages as well. Playing with data implies hearing, seeing, reading, writing, speaking, imagining, collecting, interpreting data, and also sharing it with others. It's important that learners and patients, workers see themselves in data, that they can tell stories with a purpose, and that they see the power and the limitations of data. We believe that it's important that education and health literacy, adult education, anywhere, cultivates courage and curiosity. Courage to have difficult conversations about the power or the limitations of data in their lives, and curiosity to imagine how data can change those situations, those scenarios. So in my role as in my role as an adult educator, I work in a community-based organization that provides services for Latina and Indigenous women in the Bay Area. Particularly, we have offices in 3 cities, San Francisco, Oakland, and Union City. I work closely with the staff. We have English classes for the staff, 3 mom speakers, 20 Spanish speakers, between 25 and 65. Our areas of work are gender, labor, rights, health, immigration, domestic and sexual violence, vocational training, environment and climate, and many others. And we also do work we provide training for outreach, fundraising, peer counseling, policy advocacy, and community and coalition building. I also work with the community, and my students from the community are mostly from Mexico, El Salvador, and Guatemala, and they speak English, Spanish, and MAM. They are employed in service industries and as child, patient, and senior caregivers, janitors, restaurant workers, housekeepers, and homemakers. The ages usually most of them between 20 and 49, some of them between 50 and 70, and I've had students older than 70. So once again, what does communicative justice look like in a community-based setting, adult education classroom? Here I have some examples. During the pandemic, we created our own surveys, and I have, if we look at this one, we created our surveys. We we wrote the questions in English and in Spanish, then in English. We created the Google surveys. we sent the links, we looked at the results, and we had conversations about how our community felt regarding wearing masks. We've also worked with pie charts and word clouds in multiple languages. When thinking about trust, which is something that some other panelists have mentioned as well, we have explored this in different ways, but learning vocabulary, but also having conversations about, for example, closeness. How close are these, people, these community members to you? Frequency, how often do you see them? Intensity, how much do you trust them? And here we have an example of a student, how she represents her community network. And something that I consider really interesting and important to share with you is that trust is also connected to the language that a person speaks. So which COVID vaccines will be available in Latin America? This is an activity that we have done in different occasions, because the implications of health literacy working working with adult immigrants, right? This came from my students. When we learn something here, we can also teach and share what we learn with our communities in our homes, in our home countries. So this idea of transnational leadership, it's also been really impactful for us. And how am I doing with time? Good?
You have about 3 minutes left in your 12 minutes.
Perfect. So this is an excerpt, a piece of writing that my students wrote in Spanish and English. I'm going to give you a little bit of time for you to read it. I would like to read it in Spanish, but I'm going to skip over that part. In this piece, students share how having access and having activities in their English classes that help them learn and explore working with bar graphs, pie charts, and word clouds has been really, really important for them and their families during the COVID. Another activity that has been really important for the Maya Mom community has been finding data about us, and this is where the digital part comes in a little bit more. We did this last year, and I asked students to do a Google search about information about them, and in this particular case, the student was looking for information about something work related. But I would like to focus our attention on what she said. They put information for them, for people who only speak Spanish. The information in English will not be useful for my community because they cannot understand it. People who speak MAM have the difficulty of making a record on Salesforce, because from all the information found, there is a lot in English, some in Spanish, and no results in MAM. So although this is not related to health, we can see that the amount of information that she found in particular, was not representative of what she was looking for. This activity in particular generated a lot of really interesting discussions about representation, lack of representation, misrepresentation, biases, and that leads me to share a piece by El Tímpano, a local newspaper. This is very recent. It's advocates continue the fight for better health data on California's indigenous peoples. The article shares specifically about a bill related to data, but I would like us to look at this quote in particular. Indigenous people with roots in Latin America are often considered Latinos in government surveys, erasing their identities and in turn ignoring that they may have different health needs. Indigenous peoples are constantly being lumped into a category that we ourselves don't identify with, for instance, like Latinx. If we don't exist in data, our human rights are violated. And then considering the importance of community-based organizations and working with the community, the article also shares building trust takes time. Community organizations will continue to work to encourage Latinos and Indigenous people to feel comfortable sharing their demographic information with the government whenever the option is made available in the future. As advocates, we also need to let our communities know that this is okay and it's for us, so we can count. I would like to finish my presentation sharing our the communicative justice conceptual framework and some references.
Thank you, Maria. I'm sure there may be follow-up questions. Thank you to everyone for this just very wide-ranging perspective. I wanted to just offer a few, some recap, and as if you're in the chat or thinking about a Q&A, to prepare yourself to ask questions, or I will have questions myself for our panelists. So you heard some myths that we're trying to bust, but we're also trying in doing that work to reshape the narrative around digital and data literacies. And just here are some thoughts to take away that I see cutting across the presentations today. The idea that the device guarantees you a particular kind of interaction or access to interaction or abilities to deepen your interaction, and that we're really questioning that at what are the support systems that will engage the fuller participation piece beyond access to either the internet or access to the appropriate device. So many issues around privacy have come up, and I'd love to get back to that library discussion about how they can offer real solutions to the problems that we're hearing among our adult learning communities. But the idea that people are comfortable with privacy for the specific health matters that are being discussed, and the breastfeeding one is a great example of that. And this raises the broader issue of really being able to untangle connectivity, which you can get with a good server or a good device, and the social relationships that need to encase or be embedded with this connection. And really quickly, this question about AI in public higher ed, I think we often are asking the wrong question. It's like, is AI great for learning? We're often talking about populations where the opportunity to having meaningful relationships with providers is strained already. So the question of worrying about connectivity just adds to that stacked barrier that I think that Kathy and Julie were addressing earlier. So look for places where relationships are either under-recognized or thin, and that's maybe where we need to focus more of our attention around participation and engagement. This came up in Andrea Morrison's talk this morning about, do staff have the ability to explain risk to their patients? And really reflecting on, it gave me pause to reflect, do we have the pedagogical muscle? Do we have the language that you've heard a couple people talk about to talk about what you need to learn, to talk about the different explorations of what a number means, and who's doing that professional development work? And do we have the capacity to invest in that professional development work? So important, but in the current crisis of 13 minutes for a healthcare appointment, I often wonder where those just-in-time learning moments are supported. Maria's helped us myth bust the image of who is the data scientist in the room, but also who is burdened with having to interpret data or having to ask to be included, being able to ensure participation, and knowing that some of the ways that many data tools are being propagated with little attention to the participatory roots to their use. And the goal there is rather basic, as you saw in Maria's last quote. If we democratize the data in healthcare, we're going to have better data. And with better data, we're going to tell better stories about the inequities, as well as the sources of resilience in healthcare. And then finally, I hope through venues like HARC, we can come to a better understanding and better policies where we all own the responsibility for supporting learning and engagement, and have that translate into meaningful investment into the learning end of things. I'm going to stop there and take a pause to see what might be in the chat. First of all, I think I can go back to Alex's question. Alex, I don't know if you want to unmute and state your question, or whether I can just read it aloud for you.
I don't think people can unmute.
Oh, okay. See, I'm modeling bad access. Okay, Alex asks, curious if telehealth is used or preferred less among these groups now that in-person visits might be more accessible now post-pandemic. With all these barriers, do people prefer in-person visits, or is telehealth still preferred? I know without telehealth, some don't make it to a doctor visit at all. I imagine Julie and Kathy, you just unmuted. Yeah, sure, go ahead.
Julie, feel free to jump in, even though I'll take a start at it. So we had lots of people talk about this, and the answer is not 100% one way or the other. There are wonderful affordances for people on technology to do virtual visits that answer these sort of low impact questions. It's like, I don't have to schlep all my kids. I don't have to find the transportation. I don't have to find childcare to be able to go and do these basic things. But people said, but I don't want a virtual visit for things where it's regarded a child's health issue. If we need, say, weights, if we need, the different kinds of measurements of whether it's a blood test, they don't want those kinds of visits to be virtual visits. So it depends. It depends on some things. The affordances of the virtual visit are very nice for routine things. People thought it was amazing that they didn't have to travel sometimes for an hour, right, to be able to get to their provider to do something that was fairly routine. But they totally wanted the in-person visit for these serious things, especially around their children. Oh, it looks like Teresa has something to say as well.
Yeah, I will say that many people that we work with are working multiple jobs, and they get paid by the hour. So if they have to travel to a doctor's appointment, they're losing actual money. So it can be helpful to have the virtual. They feel it can be helpful to have the virtual visit. And then in talking to especially federal qualified healthcare agencies, or they are finding that many people with and across a lot of the people I've talked to across mental health, that is often preferred to be a virtual visit for many reasons. One, though, is that there's still a lot of stigma with mental health in some communities. So if you're seen going into a counseling office by people in your community, that's seen as negative. So if you can do it from a private home or wherever you might be able to get access, that's often seen as a benefit.
Thank you for that. And again, context, and how deep our understanding of what's a support versus a barrier based on an actual healthcare need. I'm wondering if we can shift to the question about AI. Samuel, I'll read your follow-up question asking about AI. More so that a chatbot or AI-assisted search might be built into something like WhatsApp, YouTube, making a tool that might appeal to people who might have access to some sort of smartphone before, instead of access to a dedicated computer device. So with the language learning model, the big data, the language learning models improving some of this. What is the, what are you hearing in your own discussions, in your own venues about the role of these AI assisted platforms?
I'm going to take just the first few takes on that, but I really invite my colleagues, because I think everybody thinks about this, and this group in particular will think about this in really rich and interesting ways. But one of the things we come up against is that Alex, the question you're asking is really assuming that the problem is the device. And it's assuming that there is sort of a one and done. Once I've learned this, I'm done. But what we find when working with learners, or what we've seen in our data and in other work that I've done with learners, is that people have to come up with these. We have to keep learning. Not only are things continuing to change, but what we need to do with them is changing as well. And so it's a way we need to be thinking. It's not just, how do I learn how to use my device to do this thing this one time? And so I think we have to shift the way we're thinking about this. And I also worry about the relationships. That's one thing we also hear is, I don't want to use the virtual visit because then I might not have this relationship with my provider, right? So I don't want to lose that. And that's a different point, but it's an important one also.
Thank you for that, Kathy. I'm wondering if that enables us to even circle back to the earlier question about why isn't Medline used more often? That's a great question for any adult educator. It got built, it has a lot of information, it's vetted. Julie, I saw you quickly have a reaction. Do you want to jump in there?
Yeah, I'll just say for many, many, many years that asking WIC families, where do you seek health information? No one has ever said to me Medline, even among those who have digital skills. I just thought that was, I appreciate that, but you're just more likely to seek things that are easily findable, easier to interpret, and frankly recommended by family and friends sometimes. And so there's just not that social component, I think, to it. Because Facebook mom groups have a large social component. They have sort of that social proof to them, and we can argue against that, but that's what I hear a lot more, things that are accessible and have a social aspect to it. But all the others from the foundational skills side answer, but that's my experience with WIC.
Yeah, and I do think that's an empirical question, right? I mean, if you have adult ed classrooms that are natural laboratories for, if we were able to introduce Medline, cultivate a community of practice around Medline, would that do exactly what Jill spoke about, or Teresa spoke about earlier, which is a diffusion of a skill? But I do think this idea of social proofing it is such a great way to think. That's a good litmus for anything in adult ed. Is there a trusted network that's associated with the skill you so desire? Oh, sorry, Sean is, I don't know if this changed our answer, but Sean is clarifying that he does mean Medline Plus, not Medline. There is also a question, and I'm sorry if I missed anything, just pop it in the chat again, but Greg O'Neill is asking, how much of the digital divide is due to lack of consumer-friendly access, or is it that healthcare is not interesting, important enough to engage in learning? 150 million people can use TikTok, millions can use Amazon or Facebook. I'll have a reaction, but I'll open it up to anybody else who would like to jump in.
Well, I think kind of building on what Julie was saying, the social media platforms are bringing community, whatever community is together. And so it's almost more imperative to belong, because if you don't belong, you're not only missing out on whether the information is good or not, but also the community. However, as Jill talked about, the concept of digital resiliency is that what is helpful, I think, to many people, especially those that are a little fearful of learning maybe more traditional computer skills, is this idea that, hey, you already have some computer knowledge. You know how to go onto Facebook, and how can you, and those skills are transferable. And so what we found with North Star is that people need to be told that explicitly, that it's not necessarily, they're not making the jump that I know how to do this, so then therefore maybe I can do this. But it really does require people to kind of point that out, and to point out how things that maybe they use for more social purposes could be, similar skills could be used in other contexts, which I find really fascinating. But especially the point that it has to be like specifically kind of spelled out.
And I think we might be engaging, oh, sorry, Jill. I think we might be mixing up sort of engaging in someone else's content and then actually posting and creating content your own. And so just to add to what Teresa's saying, sorry, Jill, go ahead.
Yeah, I think I just want to jump in the same way that Julie and Teresa were leaning into this. Oftentimes, learning a particular digital problem-solving strategy or resilient skill is not having one right answer. So having one right answer being Medline Plus, or one right answer being the mom's Facebook group, really the kind of critical skill that we're trying to build is, how do you corroborate different information resources to sort out the reliability and verification process? Because that's a skill that even if Medline Plus goes away or the mom's Facebook group goes away, will remain intact, that not every piece of information that you find online from any source is going to give you all that you need to make a good healthcare decision.
And I think, Jill, too, to that, as well as to the AI kind of question, not exactly addressing should it be embedded in technology, but I think with AI and just internet searching, what's also important is that critical thinking piece of what question to ask, because AI will only give you as good of information as you ask it. And so, and the same with searching, or to your point, the where you're looking. So you have to be able to recognize the source and ask the right question, and also fact check it across multiple sources. And those are big skills that people need to learn, to be to understand this, I was talking earlier about what's the difference between literacy and digital literacy, and is it a part? And in the world we live in today, this is how you interpret things is often digitally, and it's different than in the world before there were computers.
Thank you for that. I'm wondering if, just to circle back to Greg's question, because Greg's question raises for me a way to rethink our goals in adult ed about what motivates learners to come to adult ed classrooms and say, I want to improve my digital health literacy skills. I don't know if learners ever state their goal in those terms. They either have maybe a chronic illness, or they have a young family, they've got actually immediate healthcare needs, there's an institution or a set of services they need to navigate. But I do think we can think about something I've read about in this literature around enabling constraints. So if you hearken back to Kathy and Julie's stacked barriers, one can look at those stacked barriers and remind us of the point that Andrea Morrison made this morning. Those are not people, those are life conditions. You are not the whole of your barriers, it's your life and your ability to access care equitably is an amalgam of those stacked barriers. But are there any enabling constraints? And the literature I've seen have looked at COVID as an enabling constraint. It was an awful thing, but look what it motivated us to figure out, because we had to. And I think of Maria Jose's learners, because they can't access care in Spanish, there's an enabling constraint that if it's supported around a group identity, that could be something that would lead to better policies, better access. So I think of it not being an issue of it being interesting, not interesting, but being at how are we talking about the motivation of people who, quote unquote, need digital literacy classes, need data literacy classes. And if shifting the focus to thinking about what's motivating it might open up the real opportunities for new learning.
So
Go
what I
ahead.
hear a lot, what I hear a lot is actually, if many organizations will say to learners, do you want to learn computer skills? And the answer will be, no, I'm not looking for a job. So one, I think the understanding is what worlds can it open? And there's a misunderstanding there of why one would want to learn it. And then we here at Literacy Minnesota, in the schools that we have, we are working with a large Somali population, and many of the adults are staying at home with their children, and they are really invested in their children's education. So learning digital skills to, let's say, see the emails, understand the emails from the teacher, be able to access the emails from the teacher or the parent portal, or see the grades, that's what drives people to learn these skills. So, and interestingly enough, I was talking to a learner at one point and asking what his goals were. And he said, I mean, I get to say what my goals are. And I think people are often just not asked, especially sometimes in underserved communities. So I think asking not so much from what do you want to know about digital literacy, but what do you want to be able to do? What would make your life better, or that you could, if you could do something, how would that be better?
Mm-hmm. And
The other thing,
go
sorry,
ahead, Kathy, please go ahead.
Mine's a little bit of just a little bit of a different point. So maybe you should go ahead, Marisol.
No, please go ahead.
Okay. So the other thing that I wanted to think about that I hope is a takeaway, because I see lots of our audience is people from patient education kinds of settings. And one of the things that I hope for, as those of us who work in adult learning, that the takeaway in the context of digital literacies, the development of digital problem solving, digital resilience, is to think that learning is not a one and done. And I've been in healthcare settings doing this work and seeing that someone in the clinic shows, in a federally qualified healthcare center, shows the learner how to do something, the patient how to do something. It's like, okay, they know how now. Well, that's not how learning works, right? This whole idea that it's not a one and done. I'm going to show my patient how to do this and then it's over. That's just not how most learning works. And it certainly isn't how digital literacy, digital problem solving, digital resilience is developed. The patients that we work with, that you all work with, need lots and lots of opportunities to try something, to make mistakes, to get guidance when they need it, when they have a question, that there's an opportunity for them to get that question answered, and so on. That I hope that's one of the takeaways from our presentation today, is that it needs to be, and actually not just from underserved communities, but in all communities accessing healthcare, that this learning needs to be an ongoing thing, because things are changing at a very rapid pace. But that's how learning works anyway. So the two can marry nicely in that way if we start thinking about learning as not being one and done, but as an ongoing, lifelong process of adapting to the way our world is changing.
Thanks. And if I can just add on to Kathy very quickly, I think that in healthcare a lot, we think about just get them on our platform or able to do our visits. And just if we think about public health alone, you'd have to communicate with WIC, and then maybe family planning, and then immunization, and then your child's doctor, and your own OBGYN, and then your older child's school. And so if you just think about all the digital literacies that you need just to function with your life, and I'll say that I think we're guilty in healthcare of really focused just our population, our platform, and that's not really expanding skills. And that's even just one period of time. So I know we're at the end, so go ahead. Thank you, Marisol.
Oh, Julie, that's the great way to wrap it up here. Thank you so much for being here. Take a screenshot of the slides if you want to connect with any of these folks, or if you want to practice what it would be like to reach out to your local adult education program. We'll help you get there to rehearse those conversations, because we realize that we don't all have the discourse to be able to do that in a meaningful way. Thank you for being here today and staying to the end. Have a great conference, and we'll look forward to seeing and interacting in other venues.